A reminder that these sessions are being recorded and will be available on the Health Insight website. The question and answer portion at the end will not be posted to encourage sharing, and you will receive notification when the recording has been posted. So these first couple of slides are our disclosure slides that are required for CME and continuing education. And without any further ado, I'd like to go ahead and get started. We are excited to have Dr. Susan Kelly back to facilitate today's session. You can reference the first two recorded sessions for Dr. Kelly's bio. And at this point in time, I'm going to go ahead and turn it over to Dr. Kelly.
All right, thank you, Andy. So welcome back from the holidays, everyone. We're going to take a little different tack today because you probably didn't get that much homework done in the last 2 weeks. So we're going to talk about prevention. This is seated in the area of the Infection Control Committee / Antimicrobial Stewardship Committee, and a document that shows how these two have to be pulled together is the CMS Surveyor document that should be on the website that we provided last time. So up till now, we've been talking about antimicrobial stewardship and how we are able to fill in those elements, leadership and expertise, looking at your own data, and then taking action, first of all, by implementing policies to improve antibiotic use. So today we're going to be talking about prevention, but there's also going to be some emphasis on measurement and numbers, because these things are really important for infection prevention as well as antimicrobial stewardship. And it's also going to be about data and putting together your data on your prevention with your stewardship. So we're going to learn about the impact of staff and family flu shots on resident health, talk a bit about measuring adherence with a catheter-associated UTI prevention bundle, measuring adherence to best practices in environmental cleaning, and then measuring our adherence to hand hygiene, respiratory hygiene, and isolation practices. So hopefully this will get everybody thinking a little more quantitatively. So influenza in long-term care facilities, I'm sure that many of you have experienced outbreaks. You know that influenza is deadly, is very disruptive, especially when many of your staff are also sick. It's difficult to handle. It moves explosively through your facility with just one case, often igniting an outbreak. And it involves your families and your staff as well as your residents. And there is no doubt that immunization of staff and encouraging families to get immunized protects the residents. And that's one of the most important messages that you as providers and caregivers for patients or residents need to get across to other people who are providers, caregivers, and healthcare professionals around the residents. How do we know this? This is one of my favorite studies of all time, not just because I'm Scottish by origin, but because this study could not be repeated now for ethical reasons. So near Glasgow in Scotland, they randomized 12 long-term care sites to have their healthcare workers immunized or not. So the healthcare workers were not randomized. It was actually done at the facility level. So where they offered immunization to healthcare workers, only 61% of them took the people up on it. So it was voluntary, not comprehensive. It's really important to understand that in this era, when the study was done back in the early 90s, there was no consensus in Europe that influenza vaccination should be used, especially for older people. So what happened when they immunized the healthcare workers in the long-term care facilities? Total patient mortality rates dropped by 17 to 10 percentage points, which was actually close to a 50% drop in total patient mortality over the course of the winter. They also had a 50% drop in influenza-like illness just from immunizing the staff immunization of the patients themselves was not associated with significant effects on mortality. So we know often that elderly people do not have the greatest response to flu vaccine. And depending on the match for that year with the circulating strains, you may only have a 20 to 30% effectiveness in preventing flu. However, you usually have a greater effectiveness in preventing hospitalizations and mortality. But this just shows a dramatic effect of immunizing those people around the elderly patients in the facilities. This will not be repeated study. So let me ask the group, our facility has the tools needed to achieve high levels of influenza immunization of staff. How do you feel about that in terms of your confidence? Is vaccine available? Do you have time to do it? Are there any incentives for staff to get immunized? Are you able to gather data when they're immunized elsewhere? Do you believe them when they tell you that? What kind of a job do you think you're doing on immunizing patients? Sorry, immunizing employees. Strongly agree. Yay, agree. Some people not as sure. So I hope that study alone is enough to convince you that immunizing the staff is as critical as immunizing the patients. And in fact, just in this past week's New England Journal, there was a very nice study about the effect of infections, influenza and pneumonia in particular, on subsequent myocardial infarction. So these things are related, infectious diseases and cardiology. Next slide. Okay, I think I need you to click, there we go. So how about those new fancy high-dose vaccines? This is referenced from the current guide from CDC as to preventing influenza with immunizations. And as you probably know, we have a high-dose vaccine out there that is approved only for people over 65. The main side effects of the high-dose vaccine is a slightly increased likelihood of a sore arm because it contains more flu proteins. So in these cluster randomized trials, that means that they randomize the whole nursing home to either high dose or standard dose. They saw some improvement in respiratory related admissions, maybe 13% drop there with an adjusted rate ratio, that's the 0.873, that's about a 13% drop. Pneumonia, 20% drop, all-cause admissions, 9% drop. Wasn't huge, but when you're dealing with hundreds of thousands of people, it's a lot of patients. But when you look closely at this article, the staff rates of immunization were not great. When they just did their usual program, they only immunized 26% of staff, and when they really pushed it and said, we have free vaccine for you and so forth, they only immunized about half their staff. So you can see they put a lot of effort into immunizing patients, and then there's a huge opportunity there that was lost to immunize staff. So take-home lessons. Flu is probably going to be introduced into your facility if it has not been introduced already. How can you prevent this? So the problem with flu is that you can be shedding for 48 hours before you even feel sick. We know that healthcare workers often work sick. A lot of your healthcare workers are single moms with school-age kids who are the engine of influenza, and when they've all gone back to school, which happened on Monday, that influenza is really going to get going. So you can do a lot to prevent the introduction by immunizing your staff, but you've also got visitors, and you have to communicate with them early in the season that it's important for them to be immunized as well. What can you do? So one patient may get sick, and then you have to respond. This link here actually came out a few years ago. I have another link a little later on. What constitutes the beginning of an outbreak in your facility? It's one patient. And I've dealt with this before in the VA where we had our spinal cord injury unit, and one patient we responded because those patients were quadriplegic on long-term vents, lying supine in bed, and have multiple concurrent conditions. It's going to spread like wildfire. So let's take a look at these recommendations here on this link. This came out, I believe, they haven't updated this in particular at CDC. This came out around the time of the pandemic. It says 2 cases, but let's just scroll down. Before the outbreak, it's recommended, of course, that you have your immunization program. You want to have a plan where you've determined, let's start surveillance now. Let's know what's going on in the community. We know right now that in New Mexico, influenza is widespread. We have been brown on the map for several weeks. Let's just scroll down, keep looking at this. So this is all about immunizing and immunizing your healthcare personnel. It's important to have a written response with your plan. So the plan is, there's influenza activity in the community. All residents are going to be screened every day for fever. Realize that it's not enough to look for cough illness. Many elderly people, when they get influenza, they're not going to be coughing. They will just be febrile and often have an altered mental status and look septic. Get your patients tested with a nasopharyngeal swab, whether you have to send them to the emergency room or whether you can do that in your facility. A good nasopharyngeal swab now with PCR is very, very sensitive for influenza. So the next thing, let's go down. Once you have decided that you've got influenza in your facility, which is one patient, a single laboratory confirmed case, you're already behind the 8 ball because it spreads so rapidly. Expect more cases. Then you have to make some rapid decisions. Are you going to keep everybody in their room and not allow gathering for meals and other activities? Are you going to cohort 6 patients together? And you are going to make sure that you have enough personal protective equipment and hand hygiene gel for all of your healthcare workers so that they can go in and implement standard and droplet precautions for all residents with suspected or confirmed influenza. So that if your patients are brought out of the room, and they should have a mask on. One thing that people don't really realize is that you can spread influenza by talking to someone within 3 to 6 feet. You don't have to be coughing. So that's why we have to use masks for flu patients when they come out of their rooms, even if they're not actively coughing, and that's why healthcare workers have to use masks and good hand hygiene, and in fact, droplet precautions include gloves for any anticipation of contact with the patient's secretions. So if they're helping a patient cough or move around in bed, they should have gloves. So the other big issue is getting patients on antiviral treatment. This may have to be done for an entire facility, or it may have to be done for a wing in the facility. And usually this will be done in consultation with the Department of Health, and you may have to continue the treatment for quite a few days after your last case, and also take advisement from the Department of Health about what's going on in the community. The other thing is communicating with your families and everybody else who comes into your facility that you have an outbreak, and that maybe if they're not immunized, they need to think whether or not they should come, and also the precautions that they should be taking when they visit. So let me go on to the next slide. It's a lot easier to do this when you have a written plan. So this is why I would encourage everybody to have a plan already. You go to the next slide. Okay. Who has a written plan out there for their response? There's a lot of issues to think about. By the time you have a case, it slows things down if you don't have a plan already written out, so you can just direct people to do what's necessary. Is there anybody out there with a written plan? You can chat or type in.
And if you prefer not to chat, you can go ahead and unmute your line.
Yeah. You know, we were required in acute care to have a written plan for outbreak of any kind. The influenza is actually has some specific issues that have to be addressed that really help if you have the plan written out.
Well, we do have a comment.
Okay,
Genesis has a written plan for outbreaks of all kinds.
Good, good. So Genesis with a written plan for outbreaks of all kinds, that's helpful. But as you can see, there are some specific things that have to be addressed with influenza, how you communicate to your families, and also the use of testing and contacting the Department of Health and having medication available. Let me just go to the next slide. So here's a very brief summary of a plan. These are the IDSA guidelines. I won't link to it now because they're quite lengthy, but they have a section specifically on institutional outbreaks. First thing to do is maintain awareness of your community status. You can go to the CDC website, and there's the map, and brown is bad. Sometimes the whole country goes brown. That means widespread influenza. Determine what will initiate a response. We have so-and-so with a fever. We're going to send them to the emergency room and ask specifically for flu testing and follow up on that result. Then everybody is going to be watched for symptoms. Fever, looking a bit off with the fever, not necessarily coughing in your population. Determine, are we going to throw big events where all of the residents come together? Are we going to cancel things? Are we going to keep people in their rooms for meals? If we go to prophylaxis because we have a case, are we going to do it just for that wing, the whole facility? Do we have signage ready? Do we have personal protective equipment ready? And so forth. So that's influenza. I strongly encourage you, if you don't have a plan, to look at those tools and write up a plan now. And that's a good thing to be discussing in your next infection control antimicrobial stewardship meeting. If you remember last year, we had flu that dragged on until April, even into May. So it's not too late to write up this quick plan and discuss it with your group. So here's another polling question. Our facility implements multifactorial bundles to prevent designated healthcare associated infections. So who has a bundle on something like catheter associated UTI, which you can see here with our Foley, or any other bundled intervention? So typically a bundle will be a number of interventions that have been shown to be effective individually that are then put together. Anybody with a CAUTI bundle out there that they educate on or measure or do surveillance for, a prevention bundle? In acute care, we use bundles for surgical site infection, ventilator-associated infection, catheter-associated infection. Good, so we have some bundles out there. What are people bundling on? Is it mainly CAUTI? Anybody want to type in or share? Type away.
We have a comment. I have used bundles in the past in the hospital, but need to implement here in the nursing facility.
Okay. So I think the CAUTI bundle is going to be the one that most people either are doing or find relevant in the long-term care setting. Let's go to the next slide. So there's some critical differences between long-term care setting and urinary catheters in the acute care setting. So in the acute care setting, people basically came to the realization that the best way to reduce the catheter-associated UTI was to get the catheter out. And the other best way to reduce the catheter-associated UTI was to not do cultures, because usually those patients would be getting pan-cultured for everything when it was pretty clear that they had maybe a pneumonia. And a lot of the catheters were colonized and did not represent true UTIs. So that's kind of been the thrust in acute care. Let's just get the catheters out and we'll do better. But the trouble with long-term care is that you're often taking care of a group of patients who, for whatever reason, cannot have their catheter taken out. They have neurogenic bladder, etc. Or they're male patients who have obstruction that cannot be handled any other way. Or they have complex urologic issues. And so that brings up, can we reduce catheter-associated UTIs just through really taking care of those catheters? This is one of the few studies that has looked at that. And it had to be done in pretty much an ICU setting in a pediatric hospital, which I know is kind of distant from your patients. But it is encouraging that simply being more meticulous with insertion and maintenance, daily review of catheter necessity, but I'll show you how that didn't really pan out, and rapid review of all CAUTIs, probably relating it to issues with the catheter, that they were able to drop their catheter-associated UTI rate by 50%. The Foley days were not reduced. They could not get the catheters out of these kids. What really dropped the CAUTIs was the improved care. So if you think about everything that can go wrong with a pediatric patient and a urinary catheter, it may not be that far distant from your geriatric patient when we talk about them getting ripped out and catheter-related trauma and all of those things. So how should we think about preventing CAUTIs where we can't get the catheter out for other reasons related to the patient's status? This is a picture from Dr. Mackey back, I think, in the early 2000s. It's an open access CDC article, but I've always liked this image because it breaks down the genesis of the CAUTI into extraluminal, which means the bacteria are creeping up the outside of the catheter, which could occur early because it's not inserted under optimal conditions, or late by capillary action, which can happen if the catheter is not secured and we get the catheter kind of massaging the bacteria up the urethra into the bladder. Or it can happen in the lumen of the catheter inside because you have a break in the closed system, or when you have opened the bag to drain the urine, you've contaminated it. So the whole goal here is to prevent the reflux of urine from the bag to the bladder. Because it sits in the bag, it will become contaminated over time. It sits in dependent loops. Those also are good breeding grounds. We're trying to get that forward flow of urine all the time and no backflow. We want to maintain a closed system. Occasionally, we have to open the system to drain the bag. We want to do that with a no-touch technique. We want to prevent the catheter from moving in the urethra, so we want to use securement devices. And that will also have the effect of preventing non-infectious complications, like catheters getting yanked out when patients are transported or moved around, or when patients pull them out themselves. So the staff, your staff are the ones who are frontline taking care of the patients in the catheter. Ask them about solutions. They're the ones putting the patients in wheelchairs, moving them around when they have catheters. So ask them, why do we perform hand hygiene and use gloves in handling the catheter and emptying the bag? This is because those E. coli, typically, or Klebsiella, that cause CAUTI often cause outbreaks because some of those bugs are better adapted at glomming on to the urethral mucosa and the inside of the bladder than other strains. So those virulent and resistant organisms can cause outbreaks. You don't want to spread them resident to resident. The resident might have been fine until they got colonized with that virulent strain. And then ask your staff, how are we going to keep the bag below the level of the bladder? How are we going to keep the catheter steady? Securement devices, leg straps, all of these things have to be spread out. Some work better than others. Your staff will often have solutions or make good observations as to how the catheters can be handled. Don't let the urine collect in the dependent loops. Keep the bag below the level of the bladder. Where are we going to hang the bag on the bed in the wheelchair? How are we going to transport patients? Can we use a no-touch technique in emptying the bag? Are we taking the same urine container from bed to bed, or does each patient have their dedicated urine container? That's another important issue. So what I want to bring up now is a Foley observation and quality tool that we developed here at Health Insight a couple years ago in the context of CAUTI prevention. It's an Excel spreadsheet that you can print out or do on a tablet as you go around, and you can go and look at the Foleys and the patients. And my nurse at VA used to walk into the patients and say, we're doing a quality check on your Foley, and take a look at it. And there would be a lot of issues. The Foley would not be secured. They had come back from radiology with the bag on the bed and refluxing and all kinds of problems. And she would note this down. We would see how we were doing on our quality markers, and then also look and correlate with the chart. Some of this is not so relevant to you. We would look to see, was there documentation as to why the patient had a Foley? Had there been any assessment of the need for the Foley? And ultimately, did the patient develop a catheter-associated UTI later on our infection control data? So this gives you a nice assessment, and this is something you can take back to your units and say, how are we doing in our maintenance? It does matter. It also helps if you mesh this with your catheter-associated UTI data and give some feedback as to how people are doing. But I think if they understand from that image and some of the basic concepts of how their patients get UTIs, they'll start to realize why these finer points are important. Hydration, of course, is another thing that's important to maintain the forward flow, and that may be something that should be considered as to what the urine looks like and how hydrated is the patient. So, do people think this tool would be helpful? It's a checklist, basically, that just allows you to quantify how you're doing on your Foley, and you have to go in and look in real time. Don't just look at the chart. You have to look at what's happening right then and there with the patient.
A couple of the comments are we going to get this tool? And the answer
Yes.
to that is yes. It will be posted to the website. Several people said yes, it would be fabulous. Yes, it would be helpful.
Yeah. So it's a good way just to keep staff aware that these Foleys, how they're handled really matters. Next slide. Okay. Oops, okay. So the other thing that pops up from time to time is people do funky things to try and prevent the CAUTIs. And these are from the current IDSA guidelines, specifically not recommended. Long-term antimicrobial prophylaxis with an indwelling Foley doesn't work. We're probably just going to get resistance. People used to irrigate the bladder with antiseptics, flush the bag with antiseptics, routine changing more than once a month or as needed for blockage of the catheter is not helpful. Using antiseptics to clean the perineum, not helpful. In acute care, we do use silver alloy or coated catheters. I have used them mainly to decrease the rate of positive urine cultures. But the fact of the matter is, after 19 days, these are all crusted with bacteria and urine crystals, and they're not going to work for you after 19 days. And they're more expensive. Is anybody seeing orders for any non-evidence-based practices in CAUTI prevention or doing any of these things? You may not. I hope that some of these things have gone by the wayside. I understand if people might not want to fess up. Anyway.
Okay. We have one comment that no.
Comment. No. Okay, good. All right. So as you become more aware of your catheter-associated UTIs, you're going to be integrating your infection control data into your stewardship efforts. When you look at your cultures, when you look at your policies, make sure that the cultures are not obtained from catheters in place for more than 72 hours. They will always be positive, right? Very likely positive. They'll be colonized by that time. And then it's always interesting if you have had a big breach in catheter care that you saw, or there was an incident like catheter being ripped out or something, and a CAUTI occurs, it's good to make that correlation. The other thing is with hand hygiene and going from patient to patient, make sure that you're not having clusters of like organisms with similar antibiograms. Look at the susceptibilities. You could be having an outbreak of CAUTIs that is being carried from person to person on the hands of healthcare workers. So here's a different area of focus. Our environmental cleaning staff has a strong understanding of and how to perform hygienic cleaning procedures. How do people feel about this? Do they know what hygienic cleaning is? What's the difference between that and regular cleaning? Are your environmental cleaning staff, are they incorporated into the infection control team? And is their contribution recognized? That's another important thing in terms of your teaching and communication with them. They're very, very central. So we have some people not feeling that they really have a good understanding. And that's an issue, because if you look at the data, for instance, in acute care, we know that a patient who goes into a room that previously had a patient with C. diff has double the risk of getting C. diff. And that tells you that the cleaning, the terminal cleaning of that room between patients was really important. So, next slide. So we can get rid of the poll. So what is hygienic cleaning? This really came to the fore, I think about, I would say 5 years ago, with the C. diff escalation. What we do with hygienic cleaning is we don't just remove visible soil and make the floors look super shiny, but we remove actual biomaterial, gunk, often stuff that you can't see. We pay attention to high-touch surfaces. So cleaning staff have often been very proud of their highly waxed floors and so forth, but there maybe isn't so much attention paid to things that everybody's hands are all over. The other thing that's helpful to do is to monitor cleaning efficacy and train the staff to clean what is not visible. And so we can do this with UV markers. You can't monitor every room. We found this even in acute care. We were using an ATP meter, and it was amazing that when we showed the staff that they were missing large amounts of gunk using the ATP meter, that the cleaning improved markedly, because suddenly people were able to see with the ATP what they couldn't see with their eyes. So it may look okay, but it hasn't been cleaned to the appropriate level with the right disinfectant solution. Is not okay. So then the other thing is to be sure that you're using the correct disinfectant for the job, like a sporicidal disinfectant for the rooms of patients with C. difficile, and also making sure the staff use PPE and use it correctly. You will often see your cleaning staff going from room to room wearing the same pair of rubber gloves. And one of the things they don't understand is they don't understand the PPE is not just for them, it's also to prevent them transferring pathogens from one room to the next. So let me go here. We have an example from the CDC with some pictures of high-touch areas and how you could mark these up. This is let's see, yeah, here it is. So here are some typical high-touch things that are often missed in routine cleaning. Light switch, who knew? Around the sink, very gunky. The call button, the bed controls. That thing in the middle is it's one of those bedpan washer type machines. The chair. If you go into any gastroenterologist's office, there is C. diff on the chairs in the waiting room. You know that. But I don't want to put you off your next colonoscopy. But yeah, those chairs. And so this is why we have chairs that with surfaces that can be cleaned in healthcare. They may look okay, but they're not clean. The rails in the bathroom and the doorknob. So these are things that need to be covered by your environmental services. There's different ways to do this. They can use a checklist. Now, one of the things that really gets me is that we ask surgeons to use a checklist, surgeons who probably have several degrees, right, and many, many years of training, and we still need a checklist to make sure everything is done before the patient undergoes surgery. But we have people doing a very complex task, which is cleaning a patient's room and having to hit all of these areas effectively, and they're not using a checklist. So the checklist is helpful. One other way to do it, which may or may not work for you, is to have them go through the room left to right. But whether or not they can handle that because of the geography of the room, or with getting interrupted, or having to change tools, change solutions, that's another issue. So there has to be some system to ensure that everything gets cleaned, especially the high-touch areas, and not just producing beautiful, shiny floors. We need these done as well. The next slide.
Before we move on, we have a question in the chat. Do these areas apply to just known rooms with infections or everyone?
These are everyone, okay? So this cleaning should be performed for all of your patients, because remember, say you have somebody who just got out of the hospital, they are colonized oftentimes with pretty resistant bacteria, and their surroundings will be contaminated with gram-negative rods in the bathroom and so forth. And you don't want those organisms spreading around your facility. So you want we can't tell sometimes if the bugs are dead or alive. When we use ATP, we just call it biomaterial. We don't really know what it is, but patients scatter this around them. And usually the more debilitated the patient is, the more likely they are to have organisms on their skin that healthier people may not have. And then that patient spreads them around their environment, and then they can spread to the next patient. And often, as we've discussed earlier in this series, those organisms nowadays in your older patients, especially with frequent hospitalizations, they're resistant and hard to treat. So environmental cleaning is very important, not just for C. diff, but some of your patients may be shedding influenza, for instance, Staph aureus, MRSA, VRE in their stool, enterococcus. They acquire what has been called in infection control the fecal patina, and then they spread that around their environment. So it's really for everybody. The difference is with C. difficile that you'll be using a sporicidal cleaning agent, cleaning solution, because a regular disinfectant will not kill the spores of C. diff. Go to the next slide. Okay. So some discussion questions. Is anybody out there monitoring the effectiveness of hygienic cleaning? Doing any training with gel pens, fluorescent gel pens? Any other methods to monitor it? Watching staff clean, say, from left to right through the room. Are your cleaning staff good with looking at the isolation status of the patient and putting on the appropriate PPE? Do you have a good way to communicate with them? This is sometimes tricky in long-term care because you have the issues of HIPAA and patient confidentiality and putting things on the outside of the door more than we do in acute care. And then have you seen your staff change their gloves and do hand hygiene between rooms? Or are they just going from room to room with the same gloves on? But what have people observed with their cleaning staff? A lot of this interaction really is so important to have cleaning staff who feel part of the team and who are invested in how the patients are doing. We had a wonderful cleaning person in the newborn ICU at UNM years ago who kind of addressed a Joint Commission surveyor all by herself and was able to demonstrate how she cleaned in great detail and did wonderfully during that survey. So, you know, imagine if you had a surveyor come and they decided to talk to your cleaning staff, would they be able to articulate why they're cleaning the way that they do? And articulate that in terms of infection prevention.
We do have one comment.
Yeah.
My staff does not change gloves regularly between contaminated and clean with a single resident.
Right. So is that referring to nursing staff or cleaning staff?
Not sure. wait and see.
That's nursing staff, sorry.
Right, exactly. So if you look at we're going to get into hand hygiene in a second, but when you look at the CDC or WHO guidelines, it's very important to realize there are areas on patients that are more contaminated than others. And you have to teach your staff to go clean to dirty, right? So we would say, use your gloves to look, say, at the IV site, and do that first before you use your gloves to check the Foley site, that kind of thing. So making them aware that their glove use is there for several different reasons. It's not just for protection against bloodborne pathogens. It's also to protect your hands from becoming really contaminated, and that makes hand hygiene less effective and more difficult to achieve. So they need to be aware of that dual thing with gloves, and then be aware the outside of the gloves can be really contaminated, and they don't want to go back and contaminate a clean area on that patient. Say, if they're around their mouth, they could be transferring bugs from, fecal oral. It's not great.
There's a couple more comments. One says, I do observe housekeeping to make sure they change their gloves. Sometimes I feel they don't think about changing their gloves, and I have to educate them a lot.
Right. So there's a strong tendency to use gloves thinking it's just to protect me, and not realizing that the outside of the gloves is also a vector, and as dirty as your hands or more dirty, going from room to room.
And the last comment is, our EVS department is subcontracted. There's a huge turnover of staff, and leadership techniques are generally very poor. And I did the glow light testing, and the results were only 38% compliant.
Wow, so somebody has done glow light. That's really good. And I'm actually surprised your results were that good. 38% compliant on glow light is actually not bad when you haven't really trained on it. So I think it's hard dealing with turnover, but I think actually these employees appreciate training, and they respond to it when they're told that their role is really important and that they can improve when you do it in a positive way. So I'm really excited somebody's already done a glow light. So how about some other areas of infection prevention? Reality checking on our hand hygiene, respiratory hygiene, and isolation precautions. So who has actually done hand hygiene observation with their own eyeballs in their facilities, and what are the barriers to doing this? Anybody with this experience? It's a real eye-opener. So I remember the first time hand hygiene really started to be looked at closely around 1999 when I first went to UNM. And I took myself to the surgical ICU to observe. And I sat there with my clipboard, and I saw people washing their hands with soap and water, which is often what we had then, for about 3 seconds, which is totally ineffective. And then when they saw me observing them, suddenly the adherence went to about 30 seconds to a minute of, this kind of thing. And that was probably totally unrealistic. The ICU is not that hard to observe because you typically have a glass door, or, you can sit in front of a cubicle. But observing in long-term care probably has a lot of challenges. Any comments?
Let's see. We have one comment that says, yes, I have, but it is hard to catch everyone.
Right. So the catching is very important. Let me go to the next slide. Okay. So the first thing is to be sure that your staff know and understand the standards. I'm not that happy with teaching based on the WHO's 5 moments because it's very complicated. So when we had to deal with all of the staff, residents, and everybody, we taught basically before and after any contact with the patient or their environment, which wound up being in and out of the room. And then you would get a lot of pushback about, I went into the room but didn't touch anything. We'd say, probably you still touched something, right? So the other thing is to make sure that they know that the soap and water is for 15 seconds under the warm running water, and you have to get all the parts of your fingers, the backs of your hands, and the so-called snuff box on the back of the thumb is often missed. And then how to use gloves, as we discussed, is not just the blood and body fluids, it's also heavily soiled areas, removing the gloves and doing hand hygiene after glove removal and not using gloves as a substitute for hand hygiene. And when you get into other personal protective equipment, making sure that they know how to take it on and off in such a way, you never get to use this phrase doff, right? Don and doff, right? So that they know how to do that in such a way they don't contaminate themselves. And people don't think about this until they are dealing with something really scary like SARS or Ebola, but they probably do take off masks when they're dealing with flu patients, and they don't realize if they don't do it carefully and think about where the cooties are, that they can contaminate themselves. And do their hand hygiene and don't touch their face before they do their hand hygiene.
We have a couple more comments.
Comments, yeah.
Yeah, one says when I was doing the audits, it went from 50 to 70%.
Uh-huh.
And then the other one says it's important to educate first, then monitor and do an audit.
Right. So educate first, monitor, do an audit. Someone saw the compliance go from 50 to 70%, which is pretty good. Make sure your staff can do it. And by that, make sure that you have the placement and type of your alcohol, gel, or foam dispensers correct. Make sure there's not empty dispensers around. Make sure that staff have access to lotion to prevent dermatitis. They should also understand that the alcohol gel does not, in fact, dry your hands out because it evaporates, but the oils stay on your hand. What dries your hands out is the washing with soap and water that strips the oils. So they do need to moisturize aggressively and at home. And when you're really doing a lot of patient care and doing hand hygiene as you should, sometimes you have to go home, put on moisturizer, and then put gloves on over the moisturizer at night. I'll tell you this. Make sure the supply of gloves is adequate. So, what numbers are real? We had one facility where the nurse managers' bonuses actually depended on the adherence to hand hygiene on their units. That was not conducive to real numbers, as you could imagine. When we put in our electronic monitoring at the VA, which monitored hand hygiene for every movement in and out of the room, based on the use of the hand hygiene dispenser for gel outside the room, our initial real adherence was scary low, 5, 10, 20%. And this is because we were seeing for the first time all of the opportunities for hand hygiene. So we then had a wonderful nurse who got on board with hand hygiene, worked with all the units, talked to them about what these sensors were reading. We subtracted some instances where nurses were going into empty rooms, for instance, to do things in there, or maybe getting a room in the ICU ready to receive a cardiac surgery patient. There was a lot of in and out, but no actual patient there. With that maximal efforts, with that kind of monitoring, our rate got up to 70%. I would say in healthcare that 90 to 100% is not a credible rate and it's probably being reported because you're not seeing all the opportunities, which is hard when people are going in and out of rooms, and especially in a long-term care setting where you have walls and not glass cubicles like an ICU. So other challenges in observation, being sneaky. People do improve their performance when they're being observed. Making sure, trying to figure out how you're going to figure out what happens in a two-bedded room. However, the good thing is that when you're sitting on a ward watching people flip in and out, the opportunities for hand hygiene are so frequent that you can collect a lot of opportunities very quickly. 10, 20 minutes at a busy time, you will easily have 30 to 60 opportunities for hand hygiene if you're looking fast enough. It takes a lot of concentration. Another fault people sometimes do is say, oh, we're going to give this to the ward clerk and have them collect some observations for us. You really have to be focused on doing this 100% of your attention just for a short period of time, and you will get good data. It's not something you can just look up occasionally, see somebody do a hand hygiene and mark it down, because you didn't collect the opportunities that were not taken when you observe like that. So how are facilities checking on their hand hygiene adherence, and what barriers are you encountering? Sometimes it's helpful to designate a different person, teach a different person, and have them collect their data for you. And that stops the effect of, when you walk on the ward with your clipboard of everybody suddenly behaving themselves. If you use these secret shoppers, making them do the observation is often a big education for them, because they will see what people do and improve their own practice. And if you have a smaller, closely knit staff, that may actually work pretty well. And you'll find out about some of the myths or issues that make people avoid doing hand hygiene. So you can continue to type in. I'm just going to wind up here because we're getting close to the end. I want to make sure everybody has this poster for respiratory hygiene. It's a reminder to put on your doors that we're in the flu season. Cover your cough, use tissues, put out hand hygiene for your visitors. Make sure any visitors who appear ill or are coughing are discouraged from coming, or if they have to come, make sure there's a mask. Put a surgical mask, a loose surgical mask on coughing patients. One of the problems we had in acute care was people using N95 respirators, which should not be put on patients at any time ever, because they're too hard to breathe through. So with that, I'm going to just move on to because we really are at the end, I'm just going to move on to the final slide, and you can type in your questions. We haven't talked about homework for a while, and we're going to be getting back to antimicrobial stewardship. Look at your policies, look back at webinar 3 on the website. Do we have basic requirements in place for prescribing antibiotics? Okay. Look at your infection control and antibiotic data. And then next session, we're going to be talking about implementing processes, not just policies, but processes to improve prescribing. So often this means a review and a feedback or a check in real time. Whether or not it's your definitions of infection or whether you need a treatment guideline, see where your review of the data suggests that you go next. So this will be our next session, Thursday, January 31st. Am I correct? Yes, 31st, 2 to 3 p.m. Guidelines, pathways, timeouts, and structured communication tools.